I think there are, fortunately, we are investigators practicing in the field of really novel, promising constructs that are looking very efficacious as well as very safe in patients with relapsed refractory large B-cell lymphoma. Previously, all we had was chemotherapy. And I think now the field is moving forward. And in the field of immunotherapy, I think we have had multiple drug approvals for patients with relapsed refractory large B-cell lymphoma. These are technically considered chemo-free or just targeted chemotherapy agents. For example, the FDA currently has approved, for example, tafasitamab-lenalidomide for primary refractory large B-cell lymphoma who are transplant ineligible. And then there is CAR-T cell therapy, of course, in the third-line setting. And then now in the second-line setting, axi-cel was approved for patients with high-risk large B-cell lymphoma. There was polatuzumab plus bendamustine rituximab that is approved for patients who have failed 2 lines of treatment and are transplant ineligible. And then there's loncastuximab, which is the antibody drug conjugate, which also showed very impressive responses in transplant ineligible patients who have had 2 or more prior lines of treatment. So I think this is what we currently have. But in addition to that, I think things are beginning to look very promising. And I think one of the most promising constructs, in my opinion, would be bispecific antibodies. So there was a lot of data that was presented at ASH, and these data looked very impressive. For example, the data that was presented for mosunetuzumab, glofitamab, mosunetuzumab plus polatuzumab. These were patients who were heavily pretreated, aggressive large cell lymphoma. Other relapsed refractory B-cell lymphoma patients were also included. I think most striking was the fact that some of these patients had been exposed to prior CAR-T cell therapy, and it seemed like these bispecific antibodies seemed to have efficacy in those patients as well. I think most importantly, also to note is the fact that the toxicity profile was very manageable. So of the multiple other agents that are currently being worked up in the immunotherapy forum, I would say bispecific antibodies catch my attention the most. And then, of course, we do continue to improve upon the chimeric antigen T-cell receptor constructs. So we currently have a CD19 CAR-T cell therapy, and thus these many clinical trials, which have really helped at least 40% of patients who would have otherwise succumbed to their disease historically in the past. The new unmet need is patients who relapse after CAR-T cell therapy. And I think there has been excellent data with bispecific CAR-T cell therapy, with CD22 CAR-T cell therapy. Besides just large cell lymphoma, I think there was some excellent data that was presented at TCT by Dr. Natalie Grover in patients with relapsed refractory Hodgkin lymphoma with a CD30 CCR4 expressing CAR-T cell construct. And the results look very promising so far. So I think the field continues to evolve, and we just have just so much more optimism for patients who have relapsed refractory large cell lymphoma with all of these promising novel molecules.